Waiting for Elena, it looks like. She is. All right, so this morning we're going to start a brand new topic. We're going to get into cerebrovascular circulation. So this is the arterial system which supplies blood for the central nervous system. System which supplies blood central nervous system. When we're talking about the central nervous system, the main thing we're talking about is the brain. Brain receives to 20% cardiac output. And consumes 20% of oxygen. So as you can see, the brain has a large demand for oxygen when compared to the rest of the organs of the body and its general size. So a lot of our blood flow has to make its way up to the brain. So cerebrovascular circulation can be broken down into two components. We have extracranial and intracranial. So extracranial is going to be outside the skull, extra out. And this is comprised of the carotid arteries. And with the carotid arteries, we have the CCA, the common carotid artery. ICA, internal carotid artery. ECA, external carotid artery, and we also have the vertebral artery. So I'm going to put that separate. So we have carotid arteries and vertebral arteries, one on each side. Again, with carotid arteries, we have one on each side. So these arteries can be seen outside of the skull, but they do run all the way up to the brain. So there is a portion of these arteries that we're not able to visualize, with our traditional ultrasound, because it now runs into the skull. When we're talking about intracranial circulation, the main thing we're focused on over here is going to be the circle of Willis. Oh, 2 L's, sorry. Circle of Willis. All right. All right, because you guys love my artwork so much, I'm gonna do some pictures. This is our aorta. Their aortic arch. So blood flow is going in this direction. This is our proximal ascending aorta, aortic arch, descending thoracic aorta. So first branch off the aortic arch. Right here. This is going to be our brachiocephalic artery. Cephalic artery. Also called innominate artery. Why vascular likes to give things 2 names, I don't know. Just to make our lives more complicated. We have the brachiocephalic or the innominate artery. Our second branch off the aortic arch, about here. This is going to be our left common carotid, left CCA, left common carotid artery. And our third branch off the arch is going to be our left subclavian. Subclavian artery. So our brachiocephalic artery or our nominate artery is going to branch into the right common carotid artery. So right CCA, that's going to go up. And then we're going to get the right subclavian continuing out this way. So this is right subclavian artery now. Subclavian. Got left CCA going up to the head, up to the brain. Left subclavian running out that way. So the main players that are bringing blood up to the brain are going to be our two common carotid arteries, the right CCA and the left CCA. We do have two other arteries, one on each side, that also supply blood flow up to our brain. Those are our vertebral arteries. And the vertebral arteries are branches off the subclavian. So typically your vertebral artery is going to be your first branch off the subclavian. So we're going to get a branch coming off the subclavian over here. So this is going to be your right vertebral going up to the brain. Right. Vertebral. We're also going to get that first branch coming off the left subclavian, going up to the brain as well. So left vertebral. So this picture is going to become very important for you to try and understand when we start talking about stenoses and blockages or occlusions in certain vessels and the directions that the blood flow is going to want to take and the compensatory mechanisms that the brain is going to do in order to accommodate for those blockages and those stenoses. Because the brain is, the body is an amazing thing. It doesn't want to die. So it's going to put into place all these fail safes to ensure that blood flow and oxygen is getting to the brain. So carotid arteries. So we begin with the common carotid artery. which then splits into ICA, internal carotid artery, and external carotid artery. So if we picture our carotid artery coming up the neck, blood flow going up, we're going to reach an area of bifurcation or a dilatation over here. This is referred to as the carotid bulb. Carotid bulb. So the vessel gets a little bit wider in diameter right before it splits. And it's going to split into your external ECA and internal ICA. So when you're scanning, the CCA will have no branches, no branches. The CCA is also typically located posterolateral. So it's lateral and posterior to the thyroid, posterolateral to thyroid. Some of you DMS girls have been doing thyroid. So when you sweep out lateral, that's when the common carotid artery comes in. Located posterolateral to thyroid. And it's usually deep to jugular vein. So when you're scanning, you'll typically see the jugular vein above or more anterior and the carotid artery deeper. Deep to jugular vein. That's all CCA. So as we travel up the vessel, we'll then reach the area called the carotid bulb. Again, this can also be called the carotid sinus. Carotid sinus. You may see that term as well. So that's the area of dilatation just proximal to where it's bifurcating. So carotid sinus is area of dilatation proximal to bifurcation. So the reason this area is important is because this is where we're going to tend to find our plaque developing. So carotid sinuses is common area for plaque development. So the reason for that is because we have blood traveling up the CCA. It's going to hit this fork in the road. And in this area, in the carotid sinus or the carotid bulb, you tend to get some swirling of blood. So you lose that laminar flow, that nice, laminar flow where you're getting those velocities that are fastest in the central portion of the vessel. So you tend to get a little bit of swirling, the velocities slow down in this area because the blood flow has to kind of decide, all right or left, like which way are we going? So that area is where we tend to see plaques starting to develop. We often get calcification in that area. Most of your stenoses, particularly when we're focused on stenosis of the ICA, they're going to start developing in that bulb and proximal ICA. So it's a common site for plaque development, as well as intimal thickening. So we're also going to put over here intimal thickening. So when I say intimal thickening, that means that inner layer of the vessel starts becoming thicker. And that's typically a result of hypertension, diabetes. All right, so ICA. So the ICA, that's our big player when we're talking about cerebral circulation. So the ICAs are going to supply blood for anterior circulation of brain So the ICA is typically larger and more lateral Then ECA. Extracranial, meaning outside the skull, extracranial portion of vessel will not have branches. That's going to be a useful tool to you when you're trying to determine, which is ECA, which is ICA. The ICA, when we're imaging it in the neck, we're not going to visualize any branches coming off of it. So first major branch is the ophthalmic artery. Artery. And that's going to be intracranial. Intracranial. So ophthalmic, that's going to supply blood flow to your eyes. So it's when patients have issues, with vision disturbances as part of their stroke symptoms, we try and think ICA, but it's very specific visual disturbances. But we're going to get into that a little bit later. So if we continue, up the ICA, we're now into the brain. The ICA will actually terminate in an area called the Carotid Siphon. And area of Carotid Siphon. Oh.
Dan, can you move the camera over a little bit, please?
Which way? That way.
That way. Thank you.
So at that carotid siphon, it's going to then divide or split into the middle cerebral artery. So ends in area of carotid siphon and splits into middle cerebral right out of room, anterior cerebral. So it's going to end in this carotid siphon, kind of similar to, if you want to think of it like the carotid bulb in the neck. It's an area of dilatation. And it's going to then split into the middle cerebral and anterior cerebral arteries. So ICA has both an extracranial and intracranial segments. Extracranial, we won't see any branches. Our first major branch is going to be the ophthalmic artery. That's going to 100% be on your vascular registry. 100%. They're going to ask that one form or another. And you're going to need to understand that too when we start getting into signs and symptoms of strokes, the different symptoms that patients will have manifested when they have cerebrovascular accidents. And then it ends intracranial at the carotid siphon, where you guys split into this middle cerebral and anterior cerebral arteries. The next vessel is going to be our external carotid artery. Our ECA. So this one is going to supply blood for muscles of base. It's going to supply blood flow to the scalp. It's going to supply blood flow for the neck. So ECA has multiple branches. Which are seen extracranial. So with the ECA, we're going to be able to see branches in the neck when we're scanning. So our first branch is going to be our superior thyroid artery. Superior thyroid artery. So other branches, we also have ascending pharyngeal artery. Pharyngeal. We have the lingual artery. Occipital artery. We also have the facial artery. We have the posterior auricular artery. So going to the ear. Auricular. Auricular. Maxillary artery. And the final one, or the last branch, is going to be our superficial temporal artery. The big ones to really take away that you're probably going to wind up seeing on your board exams are going to be your first branch, that superior thyroid artery. Because that we definitely see, that's actually kind of close to where the bifurcation is in the extracranial ECA. So we oftentimes are able to see the superior thyroid artery. And the other important one is going to be our superficial temporal artery, that last branch. Because there's a test that we can do to, ascertain whether we're imaging the internal or the external carotid artery. We perform a procedure called a temporal tap, where we actually apply some pressure to the temporal artery. And we can visualize that pressure that we push. So we do a series of, slight compressions on that temporal artery, and we actually can pick up those oscillations when we're Dopplering the external carotid artery in the neck. But we're going to go into that a little bit later as well. And the last vessel is going to be our vertebral. So this one supplies blood for posterior circulation in the brain. Posterior circulation of brain. So we said this is also the first branch off of subclavian arteries. An important trait for the vertebral artery, it can serve as a collateral for subclavian or nominate stenosis or occlusion. Stenosis / occlusion. So right and left vertebrals, arteries, join to form the basilar artery. So the vertebral arteries, one will come up each side of the posterior neck. You'll actually visualize it running between the vertebral columns in the back, in the brain. When you get it intracranial, they'll actually come together and join together and form the basilar artery. All right, so what do some of these vessels look like on ultrasound? So this is a nice picture here for our common carotid artery. So typically the common carotid artery is gonna have nice uniform diameter. You're not gonna see any areas of focal dilatation or aneurysmal. You'll be able to visualize the nice intimal layer. So this is a nice healthy carotid artery. You know, you don't see any plaque. You visualize a nice clean surface of the intimal layer here. And as you continue up the carotid artery, so this is blood flow is running in this direction. So this area is going to be down towards the feet. It's going to be the proximal segment. Blood flow is going to be running up toward the brain in this direction, superior. So this is going to be our area over here of the carotid bulb or carotid sinus, where we get an area of dilatation right before the bifurcation. So then this shows a picture with our power Doppler on of that carotid bifurcation. So this is going to be our area where we're going to typically start developing our plaques and our stenoses, where we'll wind up with the intimal thickening. And then it's our job as sonographers, you know, to be able to determine, you know, now which is going to be ECA and which is going to be ICA. All right, so this is actually a good picture showing that branch off the ECA. So this is going to be that superior thyroid artery, that first branch off the ECA. So that you can use that kind of as a good indicator, you know, like, all right, I'm definitely sure this is now the ECA and we have our bifurcation and this is going to be my ICA. So typically the internal carotid artery is going to have a larger diameter. It's going to be a larger vessel. And the ECA will always have this, not always, but you'll typically be able to see a branch, whereas the ICA, you won't see any branches. And you'll also be able to tell the difference when we Doppler them. So waveforms. So our CCA waveform. The way I like to kind of think of the CCA waveform, it's kind of like a mix between ICA and ECA. So waveforms in ultrasound will get their characteristics on whatever organ they're going to. So we know that vessels that are going to, our peripheral muscles will have high resistance because it's a high resistant vascular bed. Whereas vessels that are going to our organs typically exhibit low resistance waveforms because those organs need blood flow. So the brain is going to be a low resistant organ because it needs that constant blood flow, whereas the muscles of the face are a high resistant bed. So our normal CCA waveform. We'll have a nice fast upstroke and a fast downstroke. You'll get your dichrotic notch and you'll have a fair amount of diastolic blood flow. So we can say moderate diastolic flow. Our ICA. This one's going to be low resistance. So we're not going to have quite as fast of an upstroke with the ICA, but we're going to have a large diastolic component. So when you're really determining whether a vessel, is high resistance or low resistance, you really have to compare, your peak systolic velocity to your end diastolic velocity and see how they compare to each other. So with the ICA, you're going to get a much higher diastolic component compared to that peak systolic velocity, whereas with your CCA, you'll have a higher peak systolic velocity and a lower relative end diastolic velocity. And then with our ECA, this is going to be a high resistance waveform. So with the ECA, we're going to have a very fast upstroke and a small diastolic component. All right. Now we're going to do circle of Willis. God. All right, so unfortunately, circle of Willis is kind of one of those things that you're going to have to really draw out and kind of memorize like the different segments in the vessels. This is going to be especially true when this summer when we do the transcranial Doppler, like as part of the clinical rotation when you go to the hospital and doing your TCDs. So circle of Willis, it is composed of anterior cerebral artery, posterior cerebral artery, middle cerebral artery, arteries actually, because it's on each side. I apologize. So one on each side, arteries. And the anterior and posterior communicating arteries. So if we want to try and fill this in, down here, we're going to have our two vertebral arteries. We have a vertebral and vertebral. Our two vertebral arteries from the right side and the left side will come together and form our basilar artery. And then that basilar artery will continue up and split into our two posterior cerebral arteries. This is our posterior cerebral, posterior cerebral. And these arteries would continue off into the brain and supply the posterior circulation. So that would be your cerebellum, brain stem. So that's why we say vertebral artery is associated with posterior circulation. So for the anterior portion of the brain, mainly the cerebrum, that's supplied by the internal carotid arteries. So this is going to be our ICA. Our ICA. So our ICAs are going to be coming up the neck. Blood flow is going to be coming up. Got blood flow coming up the neck. So it's not until we get into intracerebral that we see that first branch of the ICA. So this is actually going to be our ophthalmic artery up here. We get a branch off the ICA. And we have blood flow coming around that corner. Ophthalmic artery. So blood flow goes around that turn. And heads down in towards our carotid siphon. This is going to be our carotid siphon. So then the ICA then supplies blood going in this direction to the anterior cerebral artery. Anterior cerebral. Blood flow going up in this direction. Anterior cerebral. As well as continuing in this direction, going out to the lateral portions of the brain. Out this way, in our middle cerebral arteries. Middle cerebral. Our middle cerebral. All right, so we have blood flow coming up the ICAs. They enter this little loop. We get our first branch in the brain, our ophthalmic artery. Continues around that curve. We enter into our carotid siphon, where we then get a split into blood flow going to the anterior brain through the anterior cerebral artery, and blood flow branching off into the middle cerebral artery going to the lateral portion of the brain. So ICA up around the loop, get into the carotid siphon, go out to the middle cerebral artery or up to the anterior cerebral artery. So typically these two circulation pathways are kind of working independently of each other. We have our vertebral arteries bringing blood flow up to the brain, come together, form the basilar artery, and then split into the posterior cerebral arteries and supplying the posterior portion of the brain. We have the ICAs at the same time bringing blood flow up to the anterior portion of the brain, splitting into the anterior or middle cerebral arteries. So they're working, independently of each other. But we do have connections between the two circulations in an artery called the posterior communicating artery. So we have this artery here. Which will connect both the posterior and anterior circulations. This is called the posterior communicating artery. We'll put arteries because we have one on each side. So we have one there and one here. So the reason that's so important is if we have an issue with posterior circulation, say on one side of the brain, we're able to then tap into that circulation in the anterior portion of the brain to feed that posterior portion of the brain. So it's kind of like these communicating arteries are a fail-safe. And then we also have a communicating artery between the two anterior cerebral arteries. So up here, this is going to be our anterior communicating artery. Anterior communicating artery. So the body can use that as a communication between hemispheres of the brain. So if there's an issue with right-sided circulation, cerebrovascular circulation, the left side's okay, we can use that shunt to feed the portion of the brain that has a blockage. So these communicating arteries serve as communication between anterior and posterior and right and left sides of the brain. So over here we can put serve communication or collateral between anterior, posterior, and right and left. Brain. So they serve as communication or collateral between anterior and posterior portions of the brain and right and left brain. Those communicating arteries. So, so here's your good picture for your circle of Willis. This is going to become a study tool for you when you're studying, especially when we get into transcranial Doppler. Again, we have our ICAs coming up. We enter into the carotid sinus. We have our ophthalmic artery branching off on both sides. ICA, then at the carotid sinus, we have our split into middle cerebral artery and anterior cerebral artery. And then the connection between the two is our anterior communicating artery. And again, posterior circulation, we have our vertebral arteries, one on each side coming up, joined together, form our basilar artery. Basilar artery then splits into posterior cerebral arteries. And we have a connection between the anterior and posterior circulations through our posterior communicating artery. Potential registry question might be, what is the only artery in the body that is formed by the junction of two arteries coming together? It's the vertebral artery. So this is the only actually artery in the body where you have two arteries coming together to form another artery. Typically arteries branch, so they branch and get smaller. But this is where we have two arteries come together to form a larger artery. And these are just some more charts showing your cerebrovascular circulation. And of course, what would be vascular without anatomical variants? So our most common anatomical variant for the circle of Willis would be absence or hypoplasia, meaning underdevelopment. It's very small, of one or both communicating arteries, which decreases the collateral potential. These conditions may isolate the anterior and posterior circulations or the right and left hemisphere carotid territories. So we can also have anatomical variants for extracranial circulation. So the most common of these is involving the origin of the carotid and vertebral arteries. So here Lily has a PowerPoint showing a bunch of different possible configurations for the circle of Willis. So this could potentially be a registry question, that the most common anatomical variant for the aortic arch would be over here, B, this left common carotid, instead of coming off the arch, is actually a branch off the brachiocephalic artery. Some other anatomical variants, you could potentially have a vertebral artery, the left vertebral, branching off the aortic arch. So the brain depends on a constant supply of blood. It doesn't have a store for like sugar or oxygen, like say the liver would. So it's needing a constant supply and circulation of blood. So even a momentary disruption in blood supply can have sudden symptoms for the patient and bring on cellular death. So adequate perfusion to the brain can depend on several things. Some extrinsic factors or external factors, that can affect the hemodynamics would be your systemic blood pressure. Cardiac output, how strong is your heart? How much blood is your heart pumping out? And your overall blood volume. So if patients have a low hematocrit or low blood volume, say they're anemic or they're bleeding, that all can affect how much blood flow is getting to your brain. It can also be intrinsic factors within the brain itself. So these are things that control cerebral resistance. Be such things as intracranial pressure. So say a patient had a traumatic brain injury, they have a subdural hematoma, they were hit in the head. The intracranial pressures could start elevating, and that could start restricting blood flow to the brain. So that's why I don't know if you guys have seen it, but I've seen it when I've gone to the medical ICU, the neuro ICU. Some patients that have these brain injuries, they actually remove a portion of the skull to relieve some of those intracranial pressures in order to promote blood flow and oxygenation of the brain. So CO2 and oxygen concentrations play the greatest role in modulating cerebrovascular resistance. If the brain needs more oxygen, it will produce more CO2. This will increase CO2, causing vasodilation, and will increase blood flow until enough O2 has been supplied. There's also something called compensatory cerebral vasodilation. So what that means is that if we have an issue or a blockage in one of these arteries going up to the brain, the body will try and compensate for that by dilating another vessel. So that could be the carotid artery on the opposite side. It could be, say, the vertebral artery on the same side if we had a blockage in the common carotid or the ICA on, say, the right side. The right vertebral artery may compensate and the body will dilate that vessel to increase blood flow. So there's lots of different compensatory mechanisms that the body is created, to ensure that the blood flow to the brain is maintained. So if we have disease in these compensatory mechanisms, this can lead to potential symptoms. And we also have collateralization, so collateral vessels that can bring blood flow to the brain. So collateralization, opening of collateral pathways is dependent largely on the age of the individual and the time sequence of occlusion. So collateral flow has a better chance of developing adequately in a person with slowly evolving atherosclerotic disease. So what that's saying is if the disease process is slow, if it's a chronic condition, say the plaque is slowly building up over time, the body will compensate and start developing these collateral channels. Whereas if it's an acute process, say the person all of a sudden had a clot that was in the heart that traveled up the carotid artery and is now blocking the carotid artery suddenly acutely, those collateral channels haven't had a chance to develop yet. So intracranial collateral circulation. So those are the connections that are in the brain, those anterior and posterior communicating arteries. They're large. So the large intracranial connections are in the circle of Willis. Those are the two communicating arteries. And you also have intracranial, extracranial autosomes. So you also have connections between the ECA and the ICA. So you'll have a connection between the ECA and the ICA through the ophthalmic and orbital arteries. And a branch of the ICA will also connect to the ascending pharyngeal artery of the ECA. Another communication that we could potentially have too is the occipital branch of the ECA will connect with the branch of the vertebral artery. So we also have an ECA vertebral connection as well. So occlusion of ICA produces collateral circulation to the carotid sinus through the ECA and ophthalmic arteries. So what that's saying is if we have a blockage in that carotid siphon and it's blocking blood flow getting to the anterior cerebral artery and middle cerebral artery, the blood is going to steal brain through the ECA as well as through the ophthalmic artery. So we'll wind up with retrograde or reverse flow in that ophthalmic artery. And that's what helps to produce some of the vision disturbances that you could see with patients that have strokes. Let's also know that the anterior cerebral artery and the middle cerebral artery are also supplied from the opposite anterior cerebral artery and middle cerebral artery through those communicating arteries. So if we have vertebral artery occlusion, we can also get flow shunted through branches off the ECA. So it's through the thyrocervical and costocervical arteries. So this is a good picture of what your vertebral artery is going to look like. So here we'll see the vertebral artery. This area shadowing is actually your vertebral column. So this is the bone in your vertebral columns. So we're able to visualize segments of the vertebral artery running through those vertebral columns in the neck. And we're gonna be able to, scan this when we're doing our ultrasounds here in the lab. And the flow pattern for the vertebral artery is it's going to be similar to that of your internal carotid artery, because its ultimate destination is the brain, which is a low resistant vascular bed. Just our velocities typically aren't as fast as with the internal carotid arteries. So the main thing too with our vertebral arteries is we really don't have a grading for stenosis. We care more about flow direction. Is it antegrade or retrograde? So when you're filling out your worksheet, you may not even put in necessarily a velocity, depending on the lab that you work, but they're definitely going to ask you, is it retrograde or is it antegrade? So we want antegrade. Antegrade is positive direction, forward flow. Retrograde would be a sign of a potential occlusion more proximal in, say, the subclavian or the innominate. So retrograde flow would be indicative of a Steele syndrome, but we're going to get into that a little bit later as well. This is a good example of your ECA waveform. It's a very fast upstroke, comes to a very sharp point, and a less diastolic flow component compared to that peak systolic velocity. You tend to get a deeper dicrotic notch. Sometimes you can even have a patient, elderly, they're not even able to lie back fully, so they're sitting up a little bit. You may not even have a diastolic component. It could be very, very high resistant. And this is a good example of what a nice healthy ICA waveform looks like. So again, you're not getting as sharp of an upstroke, coming to that sharp point, and you're getting a much larger diastolic component of flow compared to that peak systolic velocity. So you also have a nice spectral window. So that means you're getting nice laminar flow. And here you have a nice open, clear spectral window. So you're getting laminar flow. Does anyone have any questions about anything so far? I'm just seeing what the next PowerPoint is, because I don't know if I want to get into the signs and symptoms, or she has to save that for next week. We're actually a week ahead of schedule according to the syllabus. So that's good. I really want to kind of take my time with the cerebrovascular stuff. All right, so yeah, we can actually talk a little bit about the actual exam itself, since we're going to jump into that into the lab. All right, so our carotid exam. So we're going to start our exam imaging and transverse. So we'll do a grayscale and transverse I like to do just a quick sweep up the carotid and transverse to kind of get the lay of the land, understand exactly, if I see any plaque, appreciate it, be able to visualize if it's tortuous or not. So a good transverse sweep coming up. So your exam, you're going to start in transverse with proximal CCA. Just erasing my board. So carotid protocol. Transverse CCA. Prox. Mid. Distal. And then do transverse. I'm going to do with and without color. Transverse bifurcation. With and without color. So after we do transverse, we're going to switch now to long. And we'll do long CCA. Two D. Prox, mid, distal. Long. Patient. This is in 2D. Long ICA. 2D. Prox. Distal. ECA. 2D. So that would just image the proximal portion. So when we're assessing in 2D, we're looking for plaque, we're looking for intimal thickening, looking for calcifications, any blockages. So once we've done our 2D imaging, we're going to go back and then do color and Doppler. After 2D imaging, we go back, we do color, Doppler. Color and Doppler all segments. Pretty sure this is how Christiana does their protocol. They want you to do the 2D first, then go back and do the color and Doppler separate, unless of course you're with Io and she does it off protocol. But so we're gonna go back and we'll color and Doppler all the segments. The last thing would be our vertebral. So vertebral you could take at any segment where you see it. We're going to do our 2D color and Doppler. All right, so we'll start transverse. We'll go up transverse, then we'll do grayscale longitudinally, color and Doppler longitudinally. So this is a picture of our CCA. We see our thyroid over here, thyroid gland. So we know that we're lateral to that thyroid gland. Our jugular vein is going to be more anterior. So we have jugular vein above the carotid artery. If you're ever confused between the two, if it's a vein or not, compress. Your vein will compress, your carotid artery will not, unless you're putting a ton of pressure on them. And then that's not good. So we're going to come down approximately as far down as we could see. You may potentially be able to visualize the innominate and the subclavian and the junction of the common carotid. Sometimes you cannot. It all depends on the patient's anatomy. But you're going to try and go down in transverse as far down as you can. And continue working your way up the common carotid arteries. So you'll have proximal common carotid artery and transverse, mid, and distal. So when you get into the bulb, the carotid artery will all of a sudden change diameter. So the bulb you'll see will become much larger than your than the common carotid artery. So the common carotid is going to typically be uniform in diameter. It's going to be the same diameter all the way up. Then you get to that area of dilatation of the bulb, which is right before that bifurcation, that split. And then you wind up into the area called the bifurcation. So now that common carotid artery has split, and you have your internal carotid artery and your external carotid artery. Again, if there's any confusion between the vein, just compress. Your vein should compress. So then this is showing color flow. So this is our common carotid artery and our jugular vein. So when we put color flow on, we want to make sure that the vessel fills completely. We want to adjust our scale accordingly. Sometimes the patient, based on their cardiac output or have a weak heart, they may not have fast velocities. Or if a patient has a stenotic aortic valve, meaning there's narrowing in the aortic valve, or there's a narrowing in their aorta, they may have increased velocity. So you might wind up with a lot of aliasing in here. So you want to adjust your color scale. You also want to adjust your color gains. So this has a little bit of bleeding outside the vessel. You kind of want to try and limit this bleeding outside the vessel, but you also don't want to turn it down your gain so low that you make it look like there's plaque in here or a filling defect, you know. So you want to make sure that the vessel fills completely with color. And also when you're imaging in transverse, we have a straight box. So you want your box to be perpendicular to that flow. So no angle when we're in transverse. We have a nice straight box, straight up and down. When we continue down, or continue up, I apologize, and we wind up, we see the vessel becoming more dilated. It's larger in diameter, so now we're entering into the bulb. So the bulb, you may not have all one color, because like I said, that bulb is an area of mixing. So it may kind of look like this jugular over here. You may see some blue and some red mixing together. Typically also your velocities are going to start decreasing in this area. So you may have to adjust your scale down a little bit. And then you get into the bifurcation. So now that carotid artery, the common carotid artery is split into your ICA and your ECA. This little vessel over here is probably branch off that ECA. So this is probably your superior thyroid artery. That first branch off the ECA that we're seeing. So after we've done our transverse sweep, we're going to go back and longitudinal, and travel back up that common carotid artery. We're assessing the intimal layer. That's where the plaque is going to form along this inner intimal layer. You could see kind of a little hypoechoic intimal lining here. So we're looking for thickening of that intimal layer. We're looking for plaque development along that intimal layer, calcification. As we work our way up, we get into the carotid bulb and our bifurcation. So depending on how the carotid artery splits, we may not necessarily see this nice tuning fork, this nice split in the bifurcation. So we may only be able to visualize, you know, the bulb going into the ICA, or the bulb and the ECA. So ECA in the common carotid artery. So we may only visualize one of these segments at a time. So this is kind of an example of it here. You have your common carotid artery, your bulb going into your ICA. And then we go back and we put color on it. So again, we want to make sure that we're optimizing our images, adjusting our scale, adjusting our color gain, adjusting. Now we're going to worry about angling our boxes. So this is where angle becomes very critical, particularly when we're Dopplering. Changes in angle will change our velocity, and it can have a substantial effect on the velocities that we get. So it can mean the difference between, you know, saying, oh, this patient, you know, has a severe stenosis, or they're just, you know, mildly stenotic. And that could definitely change course of treatment. So we're going to scan as proximal as possible. We're going to go all the way down to, you know, to the clavicle, as far down as we can, and work our way all the way up. So CCA, prox, mid, distal. It looks like she has you only taking distal CCA velocity in the lab. But in the clinical setting, you're going to definitely do a proximal velocity. A lot of places will do a mid velocity and definitely a distal velocity. I'm going to do color for the CCA bulb. And we're going to do our color and Doppler for the ICA, so our waveforms. So we can see this is your nice healthy ICA waveform. Our high diastolic component, a nice open spectral window, it's nice and clear. Get a relatively fast upstroke and a nice slow downstroke. So this is nice diastolic component. Again, we in the clinical setting, we Doppler proximal, mid, and distal ICA. We typically don't do a bulb velocity unless we feel that there's a stenotic lesion within that bulb. And if we see that there's a stenotic lesion and we're getting fast velocities, we then have to interrogate the bulb, and try and measure the velocities within it. All right, so a bulb and ECA. So when we're imaging, like I said, we may not see that nice fork in the ECA and ICA. We want to really optimize our image to visualize that CCA bulb ECA or CCA bulb ICA. So we're going to do slight angulations and rotations to optimize that continuation. So like I said, most of our stenosis and plaque is going to develop within this bulb. So you want to see a nice continuous flow from the CCA into either the ECA or the ICA. So with the ECA, we only do a proximal waveform. So we'll document, if there's elevated velocities within the ECA, but there's really isn't too much surgical intervention that's done with these, as well as it's not as critical, and there's not really a grading in terms of velocities and grading of stenosis as we have with the ICAs. So there really isn't a chart to tell us like, oh, this velocity means that the artery is this much blocked for the ECAs. Sometimes we can wind up with stenosis in both, and it may be hard to determine the difference between ECA and ICA, because as we have stenosis, we'll also get increased diastolic velocity. So it may look more like the ICA, and it's those instances where we can do that temporal tap. So to find the vertebral artery, what we're going to do is we're going to get a nice picture of our CCA. We'll put our color box on, and we're going to angle posteriorly. And as we slowly angle posteriorly, the vertebral artery should come in. So here we get a nice image of our vertebral artery, and there's a vertebral vein also associated with that artery. There's actually two veins. So be careful, when you're Dopplering, that you're not actually Dopplering the vein and like, oh my God, it's going in the wrong direction. You got retrograde flow and it looks weird. You could be just Dopplering the vein. So we want to make sure you're definitely Dopplering the artery. The artery is going to be much larger in caliber than the vein. So again, we want to make sure, we're angled properly. We got our angle on the vessel correctly, that we're parallel to the walls, and we're Dopplering in the center of that vessel, because that's where we're going to find our fastest velocities, in the center of the vessel. So interpretation. So a grayscale interpretation. We're going to characterize plaque formation, measurement of percent area and diameter and stenosis. Color flow, we're going to visualize abnormal color flow filling patterns. We're going to assess for direction of flow. Spectral Doppler analysis, we want to make sure our angles are 60 degrees or less. If possible, we're going to try and keep it at 60 degrees. We're going to identify the waveforms. Do they look symmetric bilaterally? Are they normal looking waveforms? Are they pre-stenotic, post-stenotic? We're going to measure peak systolic velocity as well as end diastolic velocities. So this is for ICA stenosis criteria. So Doppler waveform should be measured with an inclination angle as close to 60 degrees as possible, but make sure that we do not exceed 60 degrees. Sample volumes should be placed within the area of maximal stenosis. Recommended to establish protocols for stratifying degree of stenosis based on Doppler measurements. So this is another chart that you're gonna have to, write down and kind of commit to memory, is these velocities. So when we're grading stenosis in the carotid arteries, we're focused on the internal carotid arteries. Those are the ones that are important to us, because those are the ones that are going to bring blood flow up to the brain. So we grade stenosis in the internal carotid arteries only. And we do that based on the velocities, the peak systolic velocities that we get, as well as we have some other grading criteria that we can add to that as well to help get a determination. But the main thing that we're looking at is our peak systolic velocities. So in the vascular lab, we don't consider a blockage or stenosis to be hemodynamically significant until we reach a threshold of 50% blockage or 50% diameter reduction. So a normal ICA velocity will have a peak systolic velocity of less than 125 centimeters per second. So any blockage below 50% will have a velocity less than 125 centimeters per second. So we could be imaging a carotid, we could see a little bit of plaque, but as long as those velocities are under 125 centimeters per second, we could say that stenosis is less than 50%. Some of the other criteria we could look at is our ECA to ICA ratio. So when we're Dopplering, we'll have the machine will actually calculate a ratio, ECA to ICA. I mean, ICA to, sorry, CCA, ICA to CCA, sorry, ICA to CCA ratio. So when we're Dopplering, I'll take that distal CCA velocity and compare it to the proximal ICA velocity and get a ratio. And the machine will calculate this for you. So you have ratios less than 2 and an end diastolic velocity of less than 40. So those are some secondary criteria we can use when grading stenosis. So as the stenosis progresses, we grade it in ranges. So the next range would be 50 to 69% stenosis. Excuse me. So with these are going to be velocities between 125 and 230 centimeters per second. And with these, we'll have increased end diastolic velocities between 40 and 100. And our ICA to CCA ratio is going to be 2 to 4. And as the disease progresses, we get into what's considered a high-grade stenosis. So these are stenoses that are 70% or greater. These are going to have peak systolic velocities of greater than 230 centimeters per second. We'll have end diastolic velocities, which are also significantly increased. So we'll have end diastolic velocities of greater than 100, as well as a ICA to CCA ratio of greater than 4. And then as we approach near occlusion, your velocities can potentially be variable at this point. You know, they could be very, very high, or they could be very, very low, or even undetectable. And then we kind of really rely on our visualization of our plaque estimate. So a good way to visualize our plaque estimate or our diameter reduction is in our transverse view. So that's why these transverse views are important. So we'll do transverse, you know, with and without color. And we can get a good visual estimate of our plaque diameter or diameter reduction. And then we can also have a total occlusion of the artery. So with that, you know, obviously we won't be able to detect any flow within the vessel. We may not even be able to visualize a vessel lumen. I think that's pretty much it for today. I think it's a good place to kind of leave off. I don't want to get into all the signs and symptoms of strokes and all that. And I think that was the next lecture. At least it'll give us a chance to get into the lab and see the carotid arteries and kind of appreciate it a little bit better. Any questions about anything so far? No, everyone's good. Yes. All right. Well, enjoy lunch. We'll end a little early. All right.
Thank you.
You're welcome.
Dan.
You're welcome.
Bye. Thank you.
Bye.